You're listening to Medscape's In Discussion series on chronic obstructive pulmonary disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Leah Witt. Dr. Witt is a geriatrician and pulmonologist at the University of California, San Francisco. At UCSF, she is also the Pulmonary Associate Chief for Ambulatory Affairs, a coach for the Pulmonary and Critical Care Medicine Fellowship, and a passionate advocate for improving the care of older adults with chronic lung disease. Dr. Witt is an associate editor, producer, and sometimes co-host with The Curbsiders, a popular internal medicine podcast where she's covered topics on chronic lung disease, geriatrics, and gender equity. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Leah Witt. Welcome back to Season 1 of the Medscape in Discussion COPD podcast series. Today, we're talking about COPD exacerbations and hospitalizations with my guest, Dr. Valerie Press. Dr. Press is an associate professor of medicine and pediatrics and is the associate chief clinical transformation officer at the University of Chicago. Her research focuses on the use of behavioral randomized trials and implementation science research methods to develop, evaluate, and implement patient and system-level interventions to improve the quality of care provided to patients with chronic diseases with a focus on asthma and COPD. Welcome to the Medscape in Discussion podcast, Val.
Thank you so much for having me.
Yeah, I'm so glad you're here. We have worked together for many years, and I'm excited to share your expertise with a broader audience. But I wanted to kick off the podcast by asking you about what's on your mind outside of medicine and healthcare. Hobby, anything, book?
Yeah, so one of my newer, hobbies is taking something I didn't used to enjoy, which is running, and trying to turn it into something that I enjoy. And I actually ran my first 5K race in October. I definitely run slower than I walk, so keep that in mind. But I really do love it, and I'm hoping to work toward a 10K, but I'm currently working through some hip issues in PT, so hoping to get back to that soon.
That's nice. And then you rack up all the free t-shirts that you can display. What's on my mind is also fitness related. I have been also trying to exercise, but because I have 2 little kids, I can't find more than 10 minutes. So I have started doing Apple Fitness Plus exercises, and they have 10-minute increments of exercise, and I am swearing by it. It's the most amazing find. Okay, so let's start with our case. We've had the same case all season. We're talking about Mr. Rivera. He's a 78-year-old man with COPD, and we have staged him as Group E COPD because he's had frequent exacerbations and hospitalizations. During his last hospitalization that we're going to talk about today, that's our focus, he came in after several days of increasing shortness of breath and coughing. His ABG showed that he had respiratory acidosis, and in the emergency room, he was treated with BiPAP. So I wanted to kick off our discussion by asking you, what is a COPD exacerbation, and does that sound like what he has?
That's a great question. I mean, I think we often think, oh, we'll know it when we see it. But the guidelines in 2023 actually updated the specifics, so we really can focus in and try to be more precise. And so nowadays, we're thinking of this as not only what we already thought about, which is that acute worsening of symptoms and event, but we're also really making sure it has increased dyspnea plus cough or sputum worsening over a short period of time, and particularly that's sustained. We know some patients can have very brief episodes of these symptoms, but we want sustainment of that. And so one thing to note is if you just have a little bit of worse dyspnea, that's maybe not a COPD exacerbation and might want to think about other diagnoses. But in this case, he does sound like he's having multiple different systems with that increased coughing along with shortness of breath, plus some of the other findings. So I think that we would definitely want to give our stamp of approval that this is probably a COPD exacerbation.
And would you be thinking about ruling out other causes? How would you think about that? Because sometimes these patients, there's sort of early closure. Like he's been hospitalized. We feel like it's the same old. And one of your expertise, we're going to talk about this later, is readmission. What do you think about that?
Well, I have a very low threshold for at least considering either co-diagnoses or alternative diagnoses. And so I'm really glad the guidelines have kind of updated that focus. I think that we want to think about triggers. Why, if it is a COPD exacerbation, is it happening? And things that can affect the lungs can help trigger that, whether it's infectious related or other chronic conditions such as heart failure and stage renal disease. Also something to think about also in these patients that gets missed frequently just because we put that COPD diagnosis on there without anything else would be consideration of PE. So I do like to have a low threshold based on other symptoms and signs and lab testing to really think about how we would go about making sure that it's either is a COPD exacerbation or not, or COPD exacerbation, but possibly complicated by something else.
That's such a good point. In our previous episode, we talked about how Occam, in older adult patients with COPD, Occam's razor is not a thing. Like, people have multiple diagnoses, and even an exacerbation could have a co-occurring pulmonary embolism, for example. So why don't we talk about initial treatment? So Mr. Rivera came to the emergency room with these symptoms. He got put on BiPAP right away. You work in the inpatient setting quite a bit and also outpatient. So I guess how would you think about triaging, deciding who gets outpatient treatment, who gets inpatient treatment, and who gets treated in the ICU?
Yes, and particularly in this case with this patient, I think given that he's an older patient and has frequent exacerbations, we're going to be a little bit heightened with this. But in general, taking a step back, there are patients with COPD exacerbations that can be treated, as you noted, in the outpatient setting. And so you really want to think about those mild or moderate cases where they don't have any particular distress. They're not meeting any kind of moderate or severe symptoms that would be worrisome, such as acidosis or hypocapnia that would warrant ventilatory support or at least monitoring if there's, new oxygen requirement or worsening. Those kinds of things would make you start worrying outside of that mild or moderate phase. And there are really nice, precise cutoffs in the guidelines where you can kind of think about what combination of vital signs, such as a really rapid respiratory rate greater than 24, heart rates that are really getting up there and are elevated at rest, right? These patients can go high with very minimal kind of activity. And then keeping that eye on the oxygen saturation. Anyone that you're concerned needs or might need soon ventilatory support, those are the patients where you're really getting into kind of the worst moderates or the severe cases that you would want to bring in. And then just one note, kind of linking back to that earlier, is this an exacerbation or not? Some patients have resting severe symptoms. And so that worsening, we kind of say it quickly, but it's really good to remember. Sometimes clinicians who know a patient can see a patient who just is kind of breathing really fast, kind of huffing and puffing, but that's usual for them. And if they don't have any of those additional cardinal signs or they don't have any worrisome vital signs, they may not even have an exacerbation, or they actually may be okay to send home with the mild kind of treatment, outpatient therapies.
Yeah, and our go-to therapies, prednisone is obviously a mainstay, and in the last couple of decades, our courses of prednisone have gotten shorter and shorter. Yeah, what is your typical practice there?
There is really good evidence published in the literature about this. There was a really nice study that looked at low-dose, short-term, 5-day oral steroids versus IV steroids that were longer-term. And what they found was pretty equivocal positive findings on the short-term low dose, so that 5 days of kind of lower-dose prednisone that you just take by mouth. And if you use IV, you didn't really get added benefit, but you did get added side effects. And so really can consider inpatient or outpatient using that 5-day or short day period with a lower dose oral steroid.
I find this to be so interesting, IV versus oral, similar efficacy. And then same for inhalers. We talked about this before. NEBs and inhalers having similar efficacy if there's correct use. But there's like a cognitive, maybe I should just call it a placebo effect, right? People feel like IV and NEBs are more powerful.
Yes.
I don't know if that's your experience.
I do. I think also we might have done some training with that and some kind of response. If that's what they've gotten in the past and they felt relief, they may be nervous. One thing I do note, we've talked about this before, I love that you pointed out this equal efficacy if you get those inhaled medicines from the devices into the lungs. Without a nebulizer, they work just the same.
Mm-hmm.
One reason I do think that patients feel more from nebulizers in the healthcare setting is that it often comes with oxygen and moisture that the exact inhalers don't use. And so what you can think about is if they require oxygen, they can still get that, and then you can teach and train on the inhalers side by side, and they still get the benefit of both.
So there's a lot of education there,
Yes.
and then we've talked about inhaler teaching, which has been a big thrust of your career too. It's so important.
Absolutely.
How about antibiotics?
Yes.
I think this is the area where there's so much more clinical uncertainty. When do we give antibiotics? How do we approach that?
There was this great study years ago that was published looking at the quality of inpatient care for COPD, and they looked at what should be given, what shouldn't be given, and they called ideal care when you got everything you should and nothing you shouldn't. And it was really hard to kind of think about antibiotics in that, because really those should be tailored. So antibiotics, you really want to think about more in patients that have some of the cardinal symptoms, particularly that sputum color change that we look at, and especially if they have really 2 or 3 of the symptoms. That's when you want to consider the antibiotics more, and then the antibiotics that have that anti-inflammatory effect as well. But you do not, as you're pointing out, kind of have to give antibiotics for every patient with a COPD exacerbation. So it's really good to tailor to those patient needs.
Yeah, that's another one where it can be hard having that conversation with patients if they have something in mind that they really want. But I guess talking about the pros and cons of antibiotics is really useful. And I like that framework of considering, like, is the sputum very purulent? I seem to be seeing a lot of people with COPD and bronchiectasis. So sometimes I'm even getting sputum cultures, though that's not guideline-based for just COPD on its own.
But it can be helpful testing. And I think that's another one where we like things to just be cookie cutter. We do this or we don't do this. It is appropriate at times to get that sputum testing. You sometimes need that to help direct your therapy, especially with that comorbid diagnosis. So I think it's a good point.
All right, well, let's talk about discharge planning. This is so important, and we're going to talk about readmissions in the next section, but discharge planning is key to reducing readmissions. How would you approach his discharge from the hospital?
Yes, I think that's a great question. I like to think about patients coming into the hospital, and as you know, an area of focus is to think, how can we keep them from coming back, right? And so yes. At discharge planning, there's the usual things that we think about. Let's make a follow-up appointment. But I think a key aspect is when. We are finding more and more that very sort of short-term 1 to 2 week follow-up for patients to check in could be very helpful to avoid those frequent early readmissions. There are a lot of reasons. Patients may not have gotten their medication, such as that important prednisone. Maybe they need a few more days at home, and you can't always kind of go straight from the hospital to the pharmacy. Maybe you don't have a ride, et cetera. And so sometimes they go a couple days without it. And now their exacerbation's getting worse, other triggers. And they also often have other conditions that may be worsening. That early check-in allows you to help with that. We already talked about inhaler teaching. I really like using inhalers during the hospitalization to do teaching. It also helps you assess, can they use them? There are times where, due to dexterity or cognitive issues, or just difficulty really understanding how to use them, where nebulized therapies are better, and you have time to set that up. So that can be part of your discharge planning, is what should that home regimen be? And part and parcel with that is that medication reconciliation, right? Making sure that sometimes we have to change what they take in the hospital based on our formularies. So really making sure we get them back on the medicines they know how to use, they're familiar with, that we teach them, and that their insurance will cover. There are a few other things I like to think about at discharge, and we can talk about this more if we're going to talk about readmissions, but sometimes there are things you want to do for patients that you can't do in the hospital, like maybe do their lung function testing. Maybe they haven't had them ever or recently. It's possible they don't even have COPD, right? Sometimes that's a clinical diagnosis that isn't correct.
Good point.
But we often don't do that in the hospital, though you can if you have that set up. And then there's also this really great treatment that I just wish everyone could get more of. It's just pulmonary rehab. A lot of our hospitalized patients in this age group often go home with home health, and you often can't prescribe outpatient pulmonary therapy and home health at the same time. So that just reinforces why that quick follow-up appointment after discharge can help you with some planning that started inpatient, but can help finish it up and wrap it up outpatient.
That is such a good framework. One of our previous guests, Dr. Stephanie Christensen, talked about a COPD exacerbation as a lung attack because it's so dangerous. For in the next year, mortality is up, lung function on average goes down, and it takes a surprisingly long amount of time for people to recover back to baseline. And I really feel like COPD does not get the respect it deserves. We don't think of a lung attack, we think of a heart attack.
Correct. Yes, it is very similar to that. It's not just, we get you totally better in the hospital and you don't have to think about it. It's a longer thread there. One thing to think about with inhaler teaching is how you teach matters. So this is another thing. So we often think of the hospital setting as this great opportunity where they're sort of there and have all the time. And it can be, and it can be a really good place to start. We like to go with guideline recommended teach back at our hospital. So recently the guidelines added how to teach, not just to teach. And so you can use teach back to really assess if patients are kind of learning appropriately. But another good reason for that follow-up appointment is inhaler use is a skill, just like driving a car. You don't just do one practice session and you're done. So using teach back and doing repeated sessions is another part of discharge planning, is when are they going to get checked in on their self-management skills, not just their symptoms or medications.
Doing the teaching, is it the nurse, the pharmacist, or physician in your practice?
That's a great question. So at our hospital, we're very lucky. We work with our pharmacy team. We actually have pharmacy students and residents who can be taught and trained how to teach the patients. And that's a great value-added role for those learners. But honestly, we can have anyone. So respiratory therapists, pharmacists, nurses, physicians, community health workers are a great partner. They're working more and more in hospitals and with patients in their homes. So as long as the trainer knows what to do, they can be trained to then teach the patient. So not everyone has all the same resources, but I like to remind folks that really anyone can be taught to teach.
We talked with pharmacist Dr. Murtarasef about how most physicians have no idea how to use inhalers. And I think I disclosed, or I'll disclose now, that I once was asked in fellowship, how do you use a tiotropium dry powder inhaler? And I was like, I think I'll go look that up on YouTube. So I don't think we do a great job in medical training teaching the device technique so that we can be the teachers in clinic. So I think I just invite everybody to watch the videos, even if you don't have your own personal experience with inhalers, to become experts.
It's a great point. And I do reinforce that we have to know a lot as physicians, and we can't know everything. And pharmacists are out there for a reason. A good tip for outpatient, where you often don't have anyone in clinic to do it, and even if you know how, you might not have time to do a whole educational session, you can actually prescribe education to the outpatient pharmacy, where they often are trained to do this kind of teaching. When patients pick up their medicines, they often sign for them. They're actually signing that they don't have any questions. But if you tell the pharmacist on your prescription, please teach the patient, that might be a way to get some of that education. If you don't know how, you don't have anyone who knows how, or you know how and you don't have time.
I'm going to start adding that to my prescription instructions. That's a great tip. Well, let's move to the next part of the case. And 2 weeks later, you see Mr. Rivera in your outpatient clinic. He does get an outpatient follow-up, notably dyspneic, and even seems a bit confused. So you decide to send him back to the emergency room for evaluation and admission. I want to talk about hospital readmission and how common is this for people who have COPD exacerbations?
Yeah, it's a great question. It's actually very common. Many years ago, Medicare and then also a research study published data that about 1 in 5 patients with Medicare get readmitted within 30 days in general. When you look at different metrics, COPD is either second or third on that list. So about 1 in 5. Now, there has been recent policies put into place and hospitals are trying to improve that. That's a whole nother conversation. But there's not always an easy fix. And what's interesting to note is that only about a third of patients with COPD come back in those 30 days for COPD. About half are in total, including those with COPD, are for respiratory, but the other half is for something else. And so a lot of our patients in this population have lots of things going on. And so we do like to think in that discharge planning about the whole patient and what else should we be keeping our eye on that could go awry after kind of having a hospitalization and being away from home.
So we've talked about how dangerous hospital admission and readmission is for exacerbations. And we talked a little bit about increased mortality. Anything else that is on the list for what patients might expect in the year following a COPD exacerbation or a hospitalization?
Yeah, the increased mortality is one that's picked up on. It's very important. And I think that's that respect you were talking about earlier with a lung attack. But there are other things. There is just often more need to use healthcare resources in general. That can be a cost burden on patients, a time burden on them and their caregivers, decreased quality of life. One thing that can happen when patients get hospitalized for COPD or something else is they often are just lying around in a hospital. There's not a lot of activity. They maybe don't feel well enough. And so they can actually get weaker and frail. And so when they go home, it's important to encourage them, as they can tolerate, to become active and not get isolated. Patients who go home on oxygen for the first time, they may not be adept and or have the resources to use oxygen outside the home, so they can kind of get stuck there and have decreased activity, which then can spiral into other things. There's also just an increased risk of future hospitalization, which leads back to that conversation about why rehospitalizations are so frequent.
So what do we know about how to prevent hospital readmission? And I know this has been the thrust of a lot of the work that you've done.
So multi-pronged approach. We need to treat the whole person and not just think about, are they admitted for this? And we'll just focus on that at that current hospitalization. We are learning more and more as a profession and as a society about how lots of things affect not just health, but social determinants of health. And so there are approaches you can use to screen for issues. Is transportation going to be an issue? Is getting medications going to be an issue? And do we have ways to solve that? A lot of hospitals, including ours, are using a meds to beds program to try and get medicines in patients' hands before they leave the hospital. That can help particularly and often with those early re-exacerbations, if it's COPD specific, or just some of the chronic diseases in general. Maybe they've been in the hospital and missed some other chronic care outpatient appointments, and then they lose track of their medications. So thinking about the whole person. For COPD specific readmissions to avoid that reoccurrence for COPD, there are really great publications coming out, a lot of evidence. Pulmonary rehabilitation, I already mentioned. It's good in general. It has been shown to actually reduce all-cause and COPD-specific readmissions in the early phase, in the sort of 1 to 3 month phase. Inhalers teaching, as we already talked about, using that teach-back approach. We actually looked at that, and we can reduce that 30-day acute care visit, that an ED or hospitalization, within a month if you use teach-back, compared to using just something like where you tell the patient, but you're not using check-ins with the patient in demonstration.
That's amazing.
So how you teach matters, and that's why we're so happy it's in the guidelines. And those quick follow-up appointments that I told you about also can really help. And then also just sequelae or consequences of treatments or therapies that you've done or need to hold. So a great example is if patients also have diabetes and you're starting them on prednisone. Make sure you're titrating those medications as well. So it's really a multi-pronged approach considering the whole patient, medical issues, and other social factors, and addressing what you can.
Your approach echoes a lot of what we talked about this season with Chris Garvey and pulmonary rehab. Pretty amazing dose-dependent effect of pulmonary rehab, reducing hospitalizations and even mortality in the first year after an exacerbation. And then with Adrienne Austin, we talked a lot about managing comorbidities. So you're right, it really is a beyond the lung, really comprehensive whole person approach that really takes a interprofessional team that you alluded to, like one profession, physicians or just pharmacists or just nurses can't do it on their own. We have to work together.
Absolutely.
Before we wrap up, do you have any resources you want to share with the listeners?
One really great resource I like to point to is the COPD Foundation. This is a website you can find by searching for COPD Foundation. They have a ton of resources for patients, where patients can access educational materials, information, groups where they can talk and meet with each other and do support. And then there's also provider-facing information and videos and sort of how to use inhalers, also how to use nebulizer machines. There are also really great videos in general. One caution is sometimes the people making the videos don't always get it exactly right. So if you happen to see something and maybe it goes against what you've seen before, it's okay. Every once in a while it's wrong. But I think the COPD Foundation is a great resource to start with. And like you said, it's interprofessional. So always phone a friend. If you're not sure, new devices are coming out every day for inhaled medications. And so this might be new to you and you might not have seen it before. Call a pharmacist or look on the website to see if they have a video on how to use that particular device.
I love the COPD Foundation app because it's hard for me, even as a pulmonologist, to keep updated on all of the different types of medications and devices. And in the last year, there's been a lot of devices or inhalers removed from the market. So sometimes I'll just scan through their medication list by class. It's really helpful.
Yes, it's a great app. Yes, I said website, but yes, I actually use the app myself all the time.
They're great. Yeah, and the website is so good too, especially for patients. Well,
yes.
Thank you so much for joining us. We have learned so much from you and really appreciate that you shared your expertise. So today we've talked to Dr. Valerie Press about COPD exacerbations, treatment, triage, and discharge planning and hospital readmissions. Thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series. This is Dr. Leah Witt for the Medscape in Discussion COPD podcast.
Thanks for listening to Medscape's In Discussion Chronic Obstructive Pulmonary Disease podcast series with our host, Dr. Leah Witt. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on chronic obstructive pulmonary disease.